Hello, I am Renato Ambrosio, and it's my pleasure to collaborate with this great meeting with my friend Ashwin Agarwal. And we, in this international conclave for ophthalmology, we have moved to international virtual meetings, but we hope soon to be together live and in presence again when we have this pandemic of the COVID-19 controlled. One of my favorite topics is keratoconus imaging, and I'll give you a quick update in the 7 minutes. This is my financial disclosures. And of course, I have to acknowledge my colleagues in BRAIN, which is completing 10 years, Brazilian Artificial Intelligence Networking in Medicine. When we talk about diagnostics for corneal ectasia, I think it's wise to understand the wisdom from the art of war. We need to understand what we're looking for, what are the enemies. We are looking for early diagnosis, prognosis, classification, and staging, more detailed follow-up. Patient orientation will be definitely guided by all this information and treatment guidance, since refraction, contact lens fitting, and surgery and management complex cases will definitely benefit from imaging. Imaging comes from anamnesis and slit lamp biomicroscopy, which is the standard, up to the most complex genetics that's still not available. But we have to understand the topography and tomography distance. The surface evaluation with topography with a placido front surface reflection is very important for the tear film analysis. We have 3D architecture analysis, front and back elevation and thickness mapping with tomography. And even tomography can go beyond with layered tomography, including the ability to measure epithelium thickness. And this epithelial thickness map is now with layers like Bowman's layer. This was pioneered by Dan Reinstein. We have great contributions with the OCT with David Huang and Yan Li. And now with the group from Bangalore, we have Bowman's layer topography. This is huge improvements that we have seen to benefit the imaging for getting information for helping the patient. We call this multimodal corneal imaging. It's important to understand data acquisition parameters. We need to have accuracy and understand the difference between accuracy and precision. Accuracy is how the measurements are close to the reference value, which is the gold standard. Precision is the repeatability. And with this information, with the robust parameters, we can develop displays, and artificial intelligence comes in a very important tool for us to get this tons amount of information. The multimodal imaging gives you a lot of information, and artificial intelligence with a very emotional and clever intelligence, we have to be keen to use this data to help the patients. So we have, for example, the Pentacam, which is a multimodal imaging with axial length and ocular wavefront beyond the Scheinfeld rotation tomography. We have different tools from the Pentacam family that give you a lot of information. And you can look at this information based on the histograms on the normal population and the disease population, which is include keratoconus and other situations like angle closure glaucoma. You have the Bell and Ambrosio display, which is over 10 years now, which gives you an enhanced evaluation for tomography. But we have even gone beyond with Pentacam Random Forest Index. Michael Bentley has also a great contribution with the progression display with ABCD, in which the change from the baseline value is compared to the deviation from the standard deviation from the precision of the measurements in a normal and a keratoconic population. So you see if this change is significant from the baseline. Also, enhanced diagnosis for laser vision correction is very important because we've gone beyond the detection of mild forms of keratoconus, and we've gone beyond considering topography and frontal corneal surface to the understanding of ectasia susceptibility. We have to understand that ectasia susceptibility is not exactly the same as form-through keratoconus, which is a recognized major risk. And based even on tomography in this great series from Steve Schallhorn, you see that about 1% of the cases with no ectasia in a very large series of LASIK cases, these cases may have form-through keratoconus or even keratoconus appearance in tomography. Even though some cases with a normal tomography, they can get ectasia, 30% in this series. So we have to understand what is form-through keratoconus. Form-through keratoconus may be defined as the eye with an abnormal topography from a patient that has normal slit lamp and distance correct vision 20/20. Steve Kleiss, differently from Yaro Rabinovitz, in a more deeper understanding of form fruits keratoconus would say that the fellow eye of the normal topography of those asymmetric cases, and those cases we call very asymmetric ectasia cases, we have learned tremendously from them. We have the very nice understanding from the Young-Tinel on topographic criteria, and this very nice theoretical separation that we see here is what we're trying to achieve with artificial intelligence. Interestingly, the systematic review, there is no criteria for defining subclinical and form fruits keratoconus in 95 studies. We have to understand there's no consensus, and my humble contribution is that ectasia susceptibility is a better term to define form fruits keratoconus. And we count that when you saw this first time, the patient had LASIK in the left eye, no surgery in the right eye, would be stable in the right eye with no surgery and qualify for LASIK, but the left eye developed ectasia, and we published in 2010 the tomographic and the ORA biomechanical parameters. Today, we can see that with the Corvis integrated with the Pentacam, which includes a random forest index to TBI, which will make it much easier to develop the understanding of ectasia susceptibility. So when we think about diagnostics for keratoconus, we have to understand what we're trying to approach, how we do that with multimodal imaging, understand artificial intelligence is key for understanding susceptibility and understanding susceptibility based on the impact from surgery, and of course, telling the patient not to rub the eye. It's always the concept of going beyond, making progress, not over, not forgetting what we have understood, and is a true revolution that's still in evolution.